Good afternoon, everyone. I'm Mike Adelberg, and I have the great pleasure of kicking off the second webinar in our 3-webinar series on the new requirements for building a successful Enrollee Advisory Committee for D-SNPs in the Medicare Advantage program. As a reminder, these webinars are a partnership led by Predict Health and Rex Wallace Consulting. And Casey Dugan and I from Faegre Drinker have the pleasure of supporting their activities. Also, as a reminder, as we did with the first webinar, please feel free to chat questions throughout the presentation. We'll take your questions at the end. We'll make sure we save time for that. And in the event we have questions that we cannot get to during the webinar, we will follow up with you one-on-one. Next slide, please. So today we have the same outstanding presenters plus me that we had in the first webinar. For those of you who don't know me, and I suspect most of you do, but for those of you who don't, I'm Mike Adelberg. I've been in and around the Medicare Advantage program since before there was a Medicare Advantage program. That includes long tenure at CMS, including a number of years as the Director of Medicare Advantage Operations and the Director of the Division of Special Needs Plans, the forerunner of today's Duals office. And my 3 esteemed co-presenters. Shub, do you want to introduce yourself next?
Yes, thanks, Mike. So I'm Shub, I'm with Predict Health. Predict Health helps Medicare Advantage plans use data, analytics, and insight to improve outcomes for themselves and for their members. Really recognizing that healthcare is local, and a lot of the issues that members face and challenges they face in their experiences tend to arise from a local and community level experiences. So we actually build communities of Medicare members understand the issues in great detail using a very data-driven approach, and use those insights and share those insights back with plans to help them address them, prioritize, and focus and drive outcomes such as retention, growth, and member experience. We work with large plans, large nationals, all the way to regional plans, and some blues thrown in, so really across the gamut, and we help them achieve improved outcomes consistently. So very excited to be here, and thank you all for joining, and let me turn it over to you, Rex, for a quick intro.
Yeah, thanks, Shub. So my name is Rex Wallace. I lead a consulting firm that works with Medicare Advantage and D-SNP plans around the country to improve quality, to really create cultures of quality. So we have deep expertise in Medicare star ratings that we leverage. As a significant part of that, we leverage customer experience insights, right? To improve the customer experience, to improve retention, to improve quality across the board. But the customer experience is so integral there. I'm excited to play a role in this conversation today. And Casey.
Hi, everyone. I'm Casey Dugan. I'm a director with Faegre Drinker, working with Mike on many different issues around the Medicaid program, Medicare Advantage, issues affecting dually eligible individuals. And I also have a pretty long background in the Medicaid space, working for the Medicaid and CHIP Payment and Access Commission. And with that, I'll turn it back over to Shub.
Great. So we're going to kick off. I'm going to kick off the webinar and get to the material. So can you turn to the next page? Great. So as Mike mentioned, this is our second in our series of webinars, but we're hosting this for the larger audience. Predict Health, my organization, in partnership working closely with Rex and Rex Wallace Consulting. Together, we're offering a solution for D-SNP plans to help them launch, manage, and benefit from this from creating high-impact enrollee advisory committees that is required by CMS, but also have an impact on driving their outcomes and improve the member experience. We think it's a strategic tool, and we see opportunities on that front. This is the second in our series, ranging from understanding we have the first one on September 1st, where it was understanding and really what are these EACs and helping everyone understand what the requirements are. The recording is available, and happy to provide those for folks who want to recap. Today's webinar focuses on the best practices for a successful Enrollee Advisory Committee. And we have next one coming up on October 5th, which is how do you launch an impactful Enrollee Advisory Committee? And this is really important because you could meet the compliance needs, but leading organizations are using this interactive opportunity to engage members and achieve better outcomes. So how do you do that? So that's on the 5th, and there will be, we'd love to see you there as well. With that, let's turn over to a quick recap of the legislation for those of you who don't know. This is something that's front and center for all of us. We're all staring down the new legislation, the new requirements from CMS that beginning plan year 2023, all and every dually eligible special needs plans will be required to establish one or more Enrollee Advisory Committee in each state they operate in. So this is a pretty big lift. The details came out in April, at the end of April, in the final rule that CMS put together. But and the requirements are at a high level, as many of you know, leaving many details up to D-SNPs. There's a lot that you have to figure out specifically, and also account for variation in the regions and the plans itself and what you want to achieve from these meetings. But there are often, in addition to the federal requirements, there are states, specific states that have their own requirements as well. And so we have a number of states that we know have prescriptive requirements around through their Medicaid agency contracts, and you can find them in your D-SNP contracts or your MIPA contracts in more detail. But these EACs are not new. Let's just or the need for EACs are not new. Let's put the legislation in context a little bit. So move to the next page. Different states have had EAC-like requirements at the Medicaid level, but this is the first time that it's being required at a federal level through CMS. But organizations may have heard of enrollee advisory boards or advisory committees, either if they have MMPs or in their PACE programs for the last few years, LTSS programs, and state Medicaid advisory committee, state Medicaid programs as well. In every one in the past, while the concept or the idea is similar, the purpose has been slightly different, and the goals have been slightly different. And we tease out those differences, and it's really important to know what the goals are versus federal versus state, because that may trip you up when it comes to the compliance needs and also driving the outcomes. The reason why CMS put this in place is very simple. Just turning to the next page. The purpose is really consistent with CMS's theme around improving care for dually eligible beneficiaries and structuring programs to better serve them. It's a big ask. Organizations, every one of you, we all use CAPs, we all use survey methods, but that still leaves a huge blind spot when it comes to serving our dual eligible members. They are hard to engage, hard to reach, and really getting the richer data and insights from them about what are the challenges. That's always been a problem. The EAC is designed to address some of that, and the question is really, how do you do that well, capture the data, and then use it effectively? CMS believes that that plans can derive significant value from engaging enrollees in defining, designing, participating, and assessing their care systems, and really understanding what members have to say. So really capturing that member voice for the dually eligible employee members. And the experiences have spoken for themselves. So experience of MMPs and PACE organizations that where similar EAC type programs have been in place really in the last few years, those have been very successful and have been quickly expanded to the D-SNP world. And so we see this rapid expansion just testament to the value that CMS puts on engaging members in these small group formats. But there's a lot you can do with the meeting, not just having the meeting itself, but really what do you do as a result of the insights collected in the meeting? Because a large purpose of this effort by CMS is using that information. And turning to the next page. We see, and many organizations are seeing EACs as a really strategic tool to achieve your plan and member goals. EAC is not just having a meeting itself, but it offers a new channel for interactive information to engage members and receive very rich and ongoing feedback on issues and challenges that members face at the local and the community level, allowing you to then create solutions or areas of focus, prioritize your attention and actions. We see organizations using the meetings to drive many outcomes within the plan. And just a sampling of them is front and center for all of us, especially on the STAR side, is member experience. This has always been a challenge in the dual world. How do you use those meetings smartly to influence member experience? Use of benefits. We create a lot of, we go to open enrollment, we have all these new plan designs. Are people using them? Are they evaluating them? Using those done right, EACs can help with the use of benefits. Just another punch list is access to care, coordination of care services, a huge challenge in some communities. Bringing us down to health equity. And this is a really important area of focus. It's also stated in the final rule as a specific goal for EACs is how do you drive and improve health equity for the vulnerable and underserved populations. Using EACs to improve member retention is front and center. I know for many folks on the call today, retention is a challenge at plans, as well as growth, managing competitiveness, and the all-important STARS ratings that we all focus on. So this is a list of areas that we've seen organizations use EAC-like meetings to drive impact for. And in the next teleconference of the webinar, we will go into greater detail on specifically how people are doing so. But today's best practices are designed to help you improve the implementation of EACs and the use of EACs driving these impact here. But doing so, for any of you who have implemented an EAC is not a trivial task. It's a heavy lift. And there are some very specific challenges for organizations looking to get started. So turning to the next page, and I'll turn it to you, Michael, to take us through some of the common challenges that you've seen in your many years in working with clients.
Yeah, thanks. Challenges that I've seen and also challenges that are identified in a really helpful report from the Center for Consumer Engagement. Those of us who have convened focus groups and in other ways gathered health plan members know that we sometimes can get members who tell us everything. Sometimes we get members who sit on their hands. Sometimes we get members who, in the process of tell us everything except what we need to hear to improve our health plans. Sometimes we're asking the wrong questions or asking it in a way that we're not getting the feedback they need. In any event, the survey we recommend to you of more than 30 MMPs conducted in 2019, so reasonably contemporary, shows that there definitely are challenges with convening a successful advisory committee. We have 2/3 of the MMPs noting we had advisory committee members who are offering personal issues rather than speaking to the plan agenda, problems recruiting enrollees, problems retaining the enrollees who are recruited, difficulties with members who are there physically but maybe not fully participating, people who don't fully understand. There are 20% who reported no challenges who probably weren't answering that fully honestly, because inevitably nothing is perfect in this world. And when you work with a large body of people, there's going to be something that can be better. There is one challenge that is not on here because MMPs would not have experienced it, but could be a challenge for those of you who operate D-SNPs that cross state lines, which is that your D-SNP, if it crosses state lines, may be working with two Medicaid programs, which may have state-specific rules with respect to the Enrollee Advisory Committee. They also might just have different wrinkles in how their own Medicaid program works and the coverages it offers, et cetera, et cetera. But there is, over and above what the MMPs encountered, multi-state D-SNPs are going to have this added complication around multi-state service area. And so I'll toss that into the mix among challenges that D-SNPs will see. Having said all this, I know this slide's a bit of a downer, but I do want to underscore, and I think we have content later in this deck that will prove my point, that first of all, there are ways to take on these challenges. And secondly, despite the challenges, make no mistake, this is an activity worth doing. And even without the requirement, I would contend you should be doing it. So I'm going to turn things over to Casey to take you through the next several slides.
Great. Thank you, Mike. Great. So I'm going to get into kind of the meat of our discussion today, talking through the best practices that we've identified for EAC operation, implementation, as well as gathering and using meaningful feedback. So we've gathered best practices through a review of a ton of different information, including public reports, toolkits, grade literature. There was a great webinar a couple of weeks ago from the Resources for Integrated Care that had some really good best practices. There's a lot of information out there because, as Shub said, this requirement is new to Medicare Advantage and D-SNPs, but it's not new within CMS programs. So there is a wealth of information. We've detailed all of our sources at the back, and we've tried to build this deck to be to include the most relevant pieces for EACs that are operating under this new requirement, but also to be responsive to a lot of those challenges that have been identified within these programs. So starting at the beginning, which is kind of the setup of your EAC, a best practice here is to define the goals and the expectations for the committee at the start. For example, the desired membership makeup, its size, the processes for making sure that membership is representative, consistent with the requirement, meeting frequency, job descriptions, if you're going to have members serve in different roles like co-chair or vice chair, things like that, making sure those are defined and documented at the outset. Same thing with bylaws, creating bylaws that govern various aspects of committee operations. So for example, how many attendees do you need at each meeting for a quorum? Are meetings going to be open to the public? We've included actually examples of a charter and a bylaws document. These are links on this slide, so you can definitely take a look at those. Another good practice as you set up the EACs is making sure that you have a way of gaining health plan leadership buy-in and a process for considering the feedback. So one way to do this is to establish a steering committee within the plan for the EAC that kind of gives you a built-in mechanism for sharing the feedback that you get with the plan leadership. So that's a really good best practice that's been identified. For the membership structure, as you guys know, there is a requirement for the EAC membership to be reasonably representative to the population that's being served. And this is actually a good plug for the next webinar, because I know that the Predict Health Rex Wallace approach to this has some really great ways of using data to kind of figure out what you would need to make sure that your EAC is representative to your membership population. But in designing this, you want to think about establishing the desired beneficiary characteristics, demographics, and perspectives. So for example, if your plan membership includes many non-English speaking beneficiaries, beneficiaries of certain races and ethnicities, beneficiaries with disabilities, those living in rural areas, you want to make sure that those are included in the EAC. You may want to consider consulting with community organizations to help determine what a representative, equitable membership would look like in your community. You may want to consider establishing multiple enrollee advisory committees, especially in larger states. So for example, if you've got multiple counties, some of them are extremely urban, some of them are extremely rural, you might want to consider multiple EACs in order to make sure that you have enough representation. You may want to consider establishing term limits. So this is something that could be documented in the initial charter as well as the bylaws. And this is something that is advantageous because it creates a clear expectation at the outset for members who are joining the EAC. And it allows you to cycle in new voices and make sure that you're getting new perspectives without having to kind of deal with sensitivities from members who may not want to roll off the committee. If you can establish those term limits up front, that's a good practice for setting expectations and allowing for new voices. Lastly, ensuring membership structures are flexible to grow and change over time. So if you start out, for example, with 10 Enrollee Advisory Committee members and you realize that that's not enough, that's not enough to make sure that all of your population is represented, you can consider amending that charter to allow for more members, just to make sure that you're being flexible and you're continuing to allow your EAC to be reflective of your membership. Member recruitment. So this has been cited as a big challenge, as you saw from that graph that Mike talked about. But there are some really good practices that can help you with this. The first is think about using an application and developing a comprehensive one that includes questions that allow you to gather basic information about the applicant. So this allows you to gather demographic information on prior experience on committees, transportation, interpretation, or other accommodation needs that you would need to provide in order to get the member to participate. So this is kind of a really great information gathering mechanism. So not only does it allow you to choose members who are in line with your goals for making sure the committee is representative, but also to ensure that you've got a range of different perspectives on the committee. This next one, using a variety of recruitment methods. This is something that's not unique to EACs. I think this is consistent with a lot of what we know about Medicaid and Medicare beneficiaries, that if you want to engage with them effectively, it really helps to use a wide range of different communication methods. So this could include mail invitations, flyers, emails, social media newsletters, leverage partners. So engage care management teams, primary care teams, community organizations. Think about asking current members for referrals. And then participating and conducting outreach at community events can also be a good way of engaging with the community. Last thing on this slide, using advanced data analytics and persona analysis to help accelerate identification, recruitment, and retention. And I know that this is also something that we'll be diving into at our next webinar on October 5th. As you're doing your recruitment efforts, it's really important to think about throughout how you're making the case for why. So why should a member with limited time and resources dedicate those time and resources to joining the committee, but not only joining, but engaging effectively? So any plan staff that's involved in recruiting should be able to make the case for why the EAC is important and how it informs plans decision-making. Same thing with the materials that you use for recruitment. They should always make the case for why. Why is it important? What are some examples of recent accomplishments from the EAC? What kind of projects are they currently engaged in? What are examples of how the plan got feedback from the EAC and incorporated it in some way or used it to make a decision? And then consider recruitment an ongoing activity. So rather than kind of only doing it in cycles, for example, if you've got term limits and you know that a bunch of people are coming up on the term limit, rather than kind of waiting for that moment, thinking about it as an ongoing process, perhaps creating a way for people to go to your website and sign up to be added to the list, to be notified when there's a position open, things like that, that allow you to tap in more quickly in case there's unexpected turnover. And then lastly, offering incentives and accommodation for participation. And I'll be talking more about that in just a minute. So once you've got members, you'll be thinking about onboarding, training, and support. So it's important to conduct some type of onboarding session for new members, provide a membership handbook or a binder with information on the EAC's policies and operations, how to request an accommodation if one is needed, how to seek technical assistance, etc. Provide basic training on the Medicare and Medicaid programs and the role of a D-SNP. So members of the EAC need to have at least a baseline level of knowledge in order to contribute meaningfully about these programs. Consider assigning new members a mentor or a buddy who has been on the EAC for a longer period. So if you're just setting up your EAC and you haven't had one before, this one is more to think about down the line, but perhaps, if you've got one right now, or if you have one that you're thinking about converting to meet this requirement, this is definitely something to think about right now. And then checking in regularly with members and considering periodic one-on-one meetings. So for retention, this is another challenge that was identified. I think it was the second most cited or among the top cited challenges that MMP cited. Some other really good practices for this. The first is pretty simple, ensuring positive experiences for members. If they're not having a positive experience, they're not going to want to continue to be participating. So this means carefully considering logistics, such as meeting locations, meeting times that are convenient, providing a virtual option, providing multiple language options, building agendas that reflect what they're interested in. So allowing members to kind of lead the way in driving the agendas, or providing some type of opportunity to add to the agenda. Using easy to understand meeting materials, so plain language, practices during the meeting, such as voting practices that are, not super complicated. I think we can all say that it's not fun to be in a meeting where there's a very complicated voting procedure or something along those lines. And then providing stipends, gift cards, incentives. And I have a couple of slides on that. The second piece of this is making it easier for members to participate. So ensuring they have a positive experience and then making it easy for them. So gathering information on members' accommodation needs. For example, do they need translation? Do they need accessible documents in addition to accessible meeting locations? So this means things like, 508 compliance materials, things of that nature. Transportation, internet capability. I know a couple of plans have in the past provided iPads or temporary portable Wi-Fi connections that members can use. This piece on providing accommodations is really, really essential to ensuring equity on the EAC. You need to make it easy for as many members as possible to participate. That's a key component of ensuring your EAC is equitable. Great. Now getting into incentives, and I know that this is something that's come up quite a bit. There were a lot of questions about this in CMS's proposed rule. In the preamble, they respond to them. Incentives in general have been widely cited as the best practice for recruiting and retaining EAC members. The challenging part is that there's no consensus best practice for thinking about the specific value or the scope of incentives that should be offered. But one common practice is to provide kind of a three-part package that includes transportation or mileage reimbursement, meal or snacks, depending on the time of the meeting, and then often an additional gift card or a stipend ranging from, for example, $25 to $100. If you're going to do that, there's more that you need to think about. For example, if you're offering kind of a cash equivalent, definitely important to make sure that you're not offering it in an amount that would affect members' eligibility for other public programs such as SSI. Also important to note that incentives work best when they match members' lifestyle preferences and interests. For example, cash incentives are generally considered less preferable because not everyone has a bank account. And then to support diverse representation, it's also important to think about ways to offer culturally relevant and specific incentives. For example, culturally relevant meals or snacks that reflects the preferences of your community and the membership. So there are some federal parameters for incentives anytime you're dealing with providing cash or anything of value, really. CMS did clarify that enrollee participation in an advisory committee is not considered a marketing activity or a personal health related activity that would trigger requirements that generally govern rewards and incentives in Medicare Advantage. However, CMS did note that MA organizations are prohibited from providing things of value like this, like cash or prizes or monetary rebates as an inducement for enrollment. Also, CMS mentioned that providing stipends, transportation, anything of value potentially implicates the federal anti-kickback statute. And then obviously, as always, plans must ensure incentives conform to relevant state or contract level requirements. So states might have stricter requirements. There are some best practices for designing incentives that can minimize the risk of running afoul of some of these federal reviews or federal rules or triggering review for compliance. One important piece of this is deciding on what the compensation structure, the incentive structure is going to be and document it. So write it down, don't deviate for some members, right? Like everyone gets the same thing or gets something that follows the same formula, documenting it clearly, making sure that whatever incentives or meals or whatever you're providing, transportation arrangements are reasonable. There's no upper limit that would apply here, but would probably want to avoid vacation destinations or extravagant meals or transportation. So keeping it reasonable and simple, holding meetings in an area that makes sense for where the beneficiaries are located or is accessible. To avoid kind of triggering the prohibition on using cash or similar type of prizes or things of value to induce enrollment in your plan. You may want to consider making sure that nothing on your messaging related to the EACs kind of advertises this to non-members. So for example, you wouldn't want necessarily to put out any marketing materials for your plan that say, oh, also you can participate in the EAC and earn $100 to non-members, right? So want to avoid anything that could be seen as inducing members to enroll in connection with a cash or cash equivalent value as you're advertising. One way to kind of get around this is to consider establishing a minimum length of enrollment to be eligible for EAC membership. So a couple of months people are enrolled in the plan, maybe 6 months to a year. It's really, there's no hard limit, but just for example, being a plan member for that length of time before joining the EAC. Great, now shifting gears to talk more about meeting logistics. We've got a few best practices on here. The first is that the EAC should meet regularly, but not so frequently as to overburden members. There's pretty good consensus that meeting quarterly is kind of the minimum to get really good regular participation and feedback. Most EACs that we've seen in other programs of similar committees are meeting monthly or quarterly. Choosing meeting locations, times, and format in consultation with members. So depending on your member makeup and you know that what they have going on, an in-person meeting may not be appropriate. For example, if you have a lot of people with complex health conditions on your EAC who are potentially immunocompromised, maybe an in-person meeting is not ideal at the moment. If meeting in person, choosing a location that's convenient, ideally familiar to members. If meeting in person, consider offering that virtual option. And then along the lines of providing accommodations and making it easy for people to participate, important to ensure that languages and translation services are available if needed. Think about designating someone to troubleshoot or provide technical assistance to people if you've got a virtual option or you're meeting virtually, and then consider providing other accommodations like childcare. Great. And so now turning to kind of the final piece of the puzzle, once you've got a great EAC going and it's working very well, or if it's not working well, but say it is, if you're using all the best practices, we want to think about how we can gather really meaningful feedback and use it. So to gather feedback, one of the best practices that we identified was using a variety of different feedback mechanisms at various stages. So that could include sending materials in advance of each meeting, providing the opportunity to offer comments or ask questions in advance, providing worksheets, quick surveys during the meeting, et cetera, to gather real-time feedback, even just like a quick hand raise to get people engaged, incorporating brainstorming sessions during the meeting so that you're getting people's ideas proactively rather than having them react to things, sending short surveys or evaluations at the end of each meeting, sending longer surveys or evaluations periodically. And then you can also consider making plan staff available between meetings if members want to provide feedback kind of offline or in a little bit of a more private setting. Great, and now using member input. The first piece of this is to implement feedback loops that make it evident to the members that the plan cares about the input that it's getting. So that could include providing updates on previous feedback that was received, keeping members informed of the status of any changes. And if the plan gets feedback but is unable to make a change in response, being able to explain the rationale for that, rather than just have it kind of sit out and languish, having members feel like that nothing really came of it. Members are a lot more likely to participate regularly and meaningfully if plans demonstrate that they do seriously consider member feedback and that feedback can actually make a difference in how the plan is making decisions. The second piece of this is implementing mechanisms for accountability within the plan. So I mentioned previously the example of establishing an EAC steering committee within the health plan that's responsible for kind of operating and overseeing the EAC and liaising with health plan leadership. Implementing a clear process for communicating the input and feedback with the health plan leadership and incorporating it into the decision-making process. So coming up with a clear documented way, or at least an established way, a process for the EAC to provide input and then have whatever staff is managing that communicate that with leadership and raise it for them. And then lastly, consider instituting a monitoring and evaluation plan to document how the plan is operated, the EAC ensured meaningful representation, and incorporated and responded to member feedback. Great, and so we've talked through quite a few best practices. We've gathered a lot more, including those related to, the bullets listed on this slide. There's much more on preparation and lead up to a meeting, developing the agenda, meeting practices, and facilitation. So we've gathered a lot of this information. We've tried to include what we think is most relevant, as well as, most responsive to the challenges that have been identified. And I know that Predict Health and Rex Wallace Consulting work with clients to communicate these and incorporate them into how they're setting this up. Again, that plug for that October 5th session will have more. But I'll also note that if you're looking to look more into these, we've included all the links to our sources at the end of the slide. And with that, I'm going to turn it over to Rex.
Thanks, Casey. Lots of great information, right? So many best practices that are documented in here that are hopefully helpful. When we really think about the intent of this requirement in the first place, right? If you look in the final rule, you don't necessarily see in the major section headings, launching enrollee advisory committees. It's more along the lines of including enrollee voices and plan governance. That's really the overarching objective here. So launching the committee, critical, but it's really that which all these best practices will help you do. Casey's last slide really touches on the kind of what do you do next? How do you give feedback back to the members? How do you make sure the plan, your partners across the plan are acting on these insights that you're gathering. And when you think about who to include in the steering committee too, right? It's a lot of the people on a lot of the areas represented in this slide, which are, we think, the core areas across the enterprise that can be impacted and should be impacted positively by the insights that we gather from these Enrollee Advisory Committees, right? So to touch on just a couple of these, right? So star ratings for one, which is over to the right, these are all interconnected, right? All of these areas, from access to care to use of benefits, coordination of care, member experience, health equity, member retention, growth, and star ratings. But stars, they all kind of roll up into stars too. So they're all interconnected, but they're all independent as well. And for stars specifically, I mean, every stars eligible D-SNP got their star rating last week. I mean, right. So this is top of mind for, I know, all of you right now and every other Medicare Advantage plan in the country. And we don't know how every plan performed. We won't know until next month, but we do know how all the cut points performed, how they changed based on industry performance. And we know member experience is not getting better. Member experience is still a major pain point for many health plans and the majority of the industry, because all the cut points are staying flat or going down. They're not getting, they're not showing that the plans are performing better. They're showing that the plans are performing worse, but that's not going to stay. We know plans will improve in the member experience, and this is an opportunity where we can leverage a requirement that we're being held to, to improve our members' experience, to improve across the board. And then I'll just, in the interest of time, I'll dig into health equity here. And Casey, can you go to the next slide? When we think about health equity specifically, right, we want to, so we have an opportunity to do two things. And we of course want to promote health equity as a result of the insights that we get from these EACs. But before we do that, we have to promote health equity within these EACs. We've had conversations about launching, about the move to digital engagement with members that should be good, that should improve experience, but it could actually promote inequity, right, if we don't do it correctly. So within these EACs, we really need to do a few things around health equity, right? So, and they're pretty foundational and pretty elementary, but should not be taken for granted. Number one, we have to ensure that these EACs, like we've talked about, they're representative of our population's demographics. And this includes race, ethnicity, language, disability, social risk factors, other social determinants of health around the underrepresented population, the vulnerable population. And that's going to require an investment in a better understanding of us and abilities to collect that data and to understand our members, and to hire health plan staff who reflect those similar backgrounds as those members, right? So that we can relate better, that we can make them feel more inclusion, more what's the B word, right? So belonging, right? Like within the committee itself, right? So, and to do that, we also need to really get involved in the community if we're not already. We need to incorporate health equity topics into these EAC meetings. That's pretty obvious, right? It's actually called out in the rule that we have to have some conversations around this. But a big part of that is making sure we and our members and our staff, have common understandings and common definitions of what is health equity, to really educate, to provide education, to provide training around these topics and around the meanings of these words. And then, really importantly, right, the last one, ensuring access to these EACs for members who have barriers. So if members have transportation insecurities, if members have lack of Wi-Fi, right? How can we make sure those members' voices are represented in these meetings and they're at the table where we're having conversations and making decisions, that are going to impact them? They have to be at the table. We have to make sure they're there and to help them remove those barriers so that they can participate in these conversations. And then next slide, once we've promoted health equity within the EAC, we can take our learnings from the EAC and really drive equity across our populations. So, with a lot of collaboration, with a lot of discussions in these committees around social determinants of health, using the disparities impact statement to really guide these discussions, and to really, include topics such as, cultural competency. So, asking these members in the meetings and having interactive drill down, conversations where we can really have a deep understanding and not rely on just like survey feedback to really understand, are they able to find a provider who looks like them, a provider who speaks their native language, who can communicate with them, who really has cultural competence. Because these can be very effective. They need to be very effective, right, at driving health equity and improving health equity across our populations. And then next slide. It's really looking ahead, right? So we have, this is our second webinar, as we've touched on, right? So we had one September 1st, one today. So first, we really dove into the regulations and what's required. Today, we got deep into best practices. And on October 5th, we're going to get into what does our solution look like? So my company partnering with Shev's company, with Predict Health, and a lot of leveraging deep analytics to really improve the way that we recruit, the way we target, the way we engage members, and then really leveraging those insights in a powerful way across the organization, building action plans, having accountability, having a steering committee to actually make sure we're improving across the board with the rich feedback that we're getting from these members. And with that, I'll turn it back to Sheb.
Yep, thank you, Rex. So tremendous amount of information here, and we have about 12 minutes. So wanted to open up for questions. We've had a few questions that have come in. So just quick reminder, you can use the chat Q&A on the Zoom to send in questions, and we'll take them in order. And if you don't get to it, we'll follow up with you directly. The first question that came in, and I'll do the triaging. So this one goes to you, Michael. Do we expect CMS to create more guidance or provide more specific guidance around either best practices or requirements for EACs before the end of the year?
Yeah, so if we say before the end of the year, my hunch is no. If you think about what's on CMS's plate right now, we have the new Part D requirements per Congress's law. We have a coming risk adjustment reg. We have all of the push coming out of the RFI that they just fielded. My hunch is they're going to wait and see for a year. And as we presented in webinar 1, CMS is choosing not to be very prescriptive right now. Having said that, CMS is going to watch what happens. And could we see a more prescriptive, a more guidance focused agency in a year or two? I think the answer to that is quite possibly.
Great, super. We'll be tracking any changes in the legislation, any new requirements, obviously, and adapting requirements for plans and programs accordingly. Second question, and this one is for you, Rex. The question is around, since EACs have, or EAC-like programs have been in place for a while, have there been examples in your experience where EAC-like programs are used to improve outcomes for plans? Just a smattering of, if there's some examples, that would be helpful.
So yeah, one that comes to mind, for me is a client who had an MMP and who had a quarterly committee, like an Enrollee Advisory Committee, like like structure. And, you know, one specific example that always resonates with me when I think about them was they held one right after AEP started, right? So I think it's 31 days from today, right, is when something like that, when AEP starts. So we're right there. When all of our Medicare members get hammered with marketing material from all of our competitors, right? So what they did was they actually had the advisory committee, all these members, take the information and basically go walk the leadership of the health plan through the process of how do they decide whether to stay or go every fall, right? As they weigh their options, as they look at competitors. And, you know, some of them had spreadsheets they brought in and actually walked through, this is what I look at, this is how I evaluate my options, you know, this is what your competitor A is doing, competitor B, premium supplemental benefits provider network, whatever is most important for them. And different members had different ways of doing that, but it was incredibly insightful for the plan to understand how members do that, number one. Number two, it gave them some really early feedback in AEP as to their competitive stance that gave them a little more insight than just kind of how we compare on Medicare Plan Finder. And as a result of that, thirdly, it let them kind of, I guess, like course correct in their OEP communications to know how to tailor their communications against certain maybe gaps in the market, right, that competitors had overtaken them on, to try to offset that or counterbalance that with some positive communications and strategies in January to prevent OEP lapses, right? So it improved retention through just a deeper understanding of what members are looking at, and then consequently it improved stars, obviously, too.
That's a great example. It also points to the fact that you can use some of the data analytics to identify who to invite to the meeting up front. So if you're relatively in a growth market or entering into a new market and you're trying to see how you compete competitively, bringing in people who've been there, who just joined, like new joiners in Q1, early on in Q1, and understanding why they joined comparatively, just as an example. You can draw real good insights for OEP. That's perfect. That's a nice closed loop right there. There's so many examples like that. I think you could extend. Retention is another issue. So if you're seeing a high retention issue, you could identify which populations are likely to leave and invite them disproportionately, while balanced, obviously. And so we'll dig into this a little bit more in detail in the next webinar, where data analytics is a real powerful tool here to help plans identify whom to reach out to, invite them appropriately, and provide, get really meaningful insight on their critical challenges, be it growth, be it use of benefits, health equity, and so on and so forth. Great. One more question. So we've got another question around identification and growth of best practices. So obviously, MMPs, PACE programs have instituted best practices that we're learning from. But now that EACs are being tested and experimented at the D-SNP level nationally, how are best practices identified, and how do we track that? So I guess the question, I'll turn it over to you, Casey, around how we've monitored best practices, and how do you think this can grow, and where the resources to identify more?
Yeah, there's a lot of resources out there. I think a great place to start, if you're looking to familiarize yourself with them and identify more, we have a really pretty robust list of sources. It's in this deck all the way at the end. So as you're opening the slides, you can go to those, including links. I think I would also point to the resources for integrated care, which works with CMS to put out technical assistance and guidance, not only on this topic, but on a variety of other topics affecting dually eligible enrollees.
Actually, Casey, we probably go to the next page. I think that following this, I think the sources are listed.
Oh yeah, yep. So here's our source list. So quite a few.
And then in addition, Predict Health and Rex Wallace Consulting and working with Faegre will be tracking best practices. So there's a lot of experimentation, innovative plans are doing to drive impact. And we've got a very data-driven way to measuring ROI and impact on each of those efforts. So EACs really are impactful because we think this is a tremendous channel that will exceed the quality and the impact that current data sources that you have, such as CAHPS, provides in improving member experience. Great. So with that, coming up on time, so we have, let me turn, Rex, any other points, Michael, before we wrap up, Casey, before we wrap up? Super. So, so this is an ongoing conversation, and we're sharing the emerging best practices, called from past experiences, but we'll be adding a whole bunch more. If you have any questions around implementing EACs, but also using your interactions with members to drive outcomes, please reach out. Our next webinar is, if you go back to the previous page, is on the 5th. And we'll be sending follow-up material. There were a few questions around follow-up material, including the deck, the recording of this webinar, but also the registration link. So please sign up. We'd love to host you again, and also share it with our colleagues and contacts. So with that, on behalf of the other speakers, Rex, Michael, Casey, thank you very much for joining us, and we hope to see you soon, and happy to answer any questions you have around this very exciting and engaging effort that we're all under.